my great pleasure to introduce a very good friend, Spanish colleague, Dr. Augusto Azuara Blanco. Even though he has most of his practice been in UK, now he's in Belfast, working for the NIH. But he's probably more recognized by all these long multi-center trials that he is involved in. He's probably the mind behind the EAGLE study, the GATE study, the JUMP in UK. He's really involved in all these glaucoma, angle-closure glaucomas, and care of glaucoma and cataract patients. So it's a real honor to welcome here to the KCASH webinars series. Augusto, un verdadero placer having you here. And
muchas gracias.
If you want, you can share your screen and enlighten us with all that knowledge about narrow angle glaucoma, please.
Thank you very much, Conrad, and colleagues and friends. Can you see my first slide?
Yes, yes.
And okay, no, as I was saying, it's a real privilege to be speaking to you. I must say that your center has a great international reputation for high quality of care and research. So, and I have friends who have been there working, and but anyway, so it's a privilege to be part. And what I would like to do is to talk about management of angle closure glaucoma over the next half an hour. That's a picture of the university building, the Queen's University Belfast. I work for both in the hospital and in the university, separate businesses, but we work together. And this is the outline of my presentation. A few comments about the setting the scene. We're going to talk a little bit about the diagnosis of, in general and in particular, of this condition. We'll have a quick overview of the treatments. You know, most of the literature on angle closure glaucoma is from East Asia, and a big question is whether an intervention or a finding in Chinese population is representative to Middle East population or a European population, but we can, you know, speculate about that a bit later. This is again a prevalence, pool prevalence of angle closure disease in European population, and as you know, angle closure glaucoma is most prevalent in East Asian Chinese population. I'm sorry I don't have good data about prevalence of this disease in Middle East. Perhaps you will, you know, I'm sure you have a better idea than I do. But what I'm trying to highlight here, that in a European population, 0.4% of the adults will have angle closure disease, and if the prevalence of overall glaucoma is about 2%, that means that at least one, if not two, out of 10 glaucomas will have angle closure. And what happens with this disease that, and we'll review later, is that is underdiagnosed because we don't tend to do clinicians gonioscopy. Anyway, so this is well familiar to the glaucoma specialists. We don't call this condition anymore narrow angle glaucoma, at least in the literature, but still narrow angle glaucoma is very widely used among clinicians. But the standard nomenclature or classification of the disease according to stages is what starts with primary angle closure suspect. These are traditionally the narrow angles with normal pressure and no glaucoma, so that the only finding is that the angles are narrow. If they have patients with narrow angles and high pressure or some changes in the angle, we would call them primary angle closure, PAC. And we now tend to use only the term of primary angle closure glaucoma when there is evidence of damage in the optic disc, and with, of course, associated field loss. Now, there are several mechanisms of angle closure disease, and some of them, the mechanisms are mixed. But the vast majority of angle closure, the primary angle closure disease, is due to pupillary block. Much smaller proportion, but perhaps the second most common mechanism is plateau iris, where the ciliary processes are placed very anteriorly, pushing the peripheral iris. But even in plateau iris, sometimes, if not often, there is a bit of a component of pupillary block. There is a mixed mechanism. There are also other ocular factors that have been associated with the disease regarding, for example, the level of iris insertion, the lens volt and position of the lens, how thick is the peripheral iris. So those are also potentially contributing factors. And of course, demographics, and I was mentioning before, is mainly East Asian Chinese ethnicity, the one that is at highest risk. Female, sex, and also age. And as you will be aware, primary angle closure glaucoma is very rare in young people. So it's only after middle age, when the lens starts to grow, when we start to see the prevalent cases. Okay, let's talk a little bit about diagnosis. I mean, these are classic studies. Perhaps we are doing better, but I suspect it's not necessarily. I mean, I could say that glaucoma experts, we all do gonioscopy in everybody who gets to our clinics with glaucoma or at risk of glaucoma. But this is not the case for general ophthalmologists. And that's a challenge, because this condition is very underdiagnosed. There is a lot of angle closure glaucomas that are managed, or angle closures that are managed with like ocular hypertension, but perhaps have a narrow anterior chamber angle. So gonioscopy is the standard to diagnose this condition. But as you know, there are alternative ways and in non-contact ways to look at the angle. And this is perhaps even more relevant now in COVID, when potentially can we assess patients without direct face-to-face contact with a non-contact instrument. So the two most commonly used tests, and there is a large literature, it would be the Van Herrick or limbal anterior chamber depth and the anterior segment OCT. So the question is, how good and how accurate are these tests to diagnose angle closure or narrow angles? So just last month, in the month of May of this year, the Cochrane library has published this systematic review. And systematic reviews, of course, is the highest level of evidence when conducted properly. I will say that the majority of systematic reviews published in the literature are of poor or suboptimal quality, but the Cochrane reviews have a stamp of quality. So I do trust, and I would suggest that you can trust this systematic review regarding the methodology and validity of the review. So let's review very briefly what's the information captured in this review that has been published. As all systematic reviews, there is a standardized process, and this is a solid research effort with a pre-specified and published protocol. And typically, there are two investigators independently screening for the literature and extracting the data for all the included studies, and also assessing the quality of each of the studies. And perhaps, forgive me if I go a little bit into detail, but I would like to just share with you the QUADAS 2 effort. This is how we assess quality of diagnostic studies. Just give me a couple of minutes, please. So this is a checklist designed, again, to evaluate the quality of diagnostic accuracy studies, and is the Mark II. And there are 4 domains. So when we look, and especially I'm thinking about the residents and trainees, if you do journal clubs and you are evaluating diagnostic accuracy publication from a good journal, I would suggest that you use the quadrats to look at the quality of the publication. And there are 4 domains: how the patients were selected. For example, if you have a consecutive sample of people, it's stronger that you self-select a group of patients. Another regarding patient selection, most of the literature on diagnostic studies will use a known group of patients with the disease, in this case with glaucoma or angle-close glaucoma, and then they will recruit a group of normals, or in this case with open angles, and use the test. And this has a major flaw, because again, this is not telling you how this test will perform in real life. So the proper design for a diagnostic study, you shouldn't know when you apply when you design the study, you shouldn't know which one has narrow angles or the disease, and you shouldn't know which is the control or normal or open angles. And then you apply the new test and the reference standard, and then you evaluate the diagnostic accuracy. So, so sorry about that divergence. So the 4 domains is patient selection, critical thing about the diagnostic test. Of course, that should be masked. The person doing the Van Herrick OCT should not know what's the reference standard where the patient has narrow angles, because there is always bias in the interpretation. So the masking is essential in the quality of a study. And of course, the reference standard gonioscopy is not a perfect reference standard, because there is a bit of, it's a clinical examination. There may be a bit of variability, but that's still the best reference standard we have for the condition. And the other domain is about the flow of patients and timing. Okay, so after that, a long introduction. So there are, you know, lots of studies that were found, and here, I mean, the pool sensitivity and specificity is in the mid-80s, but you can see the confidence intervals are very wide. That means that, you know, this pool estimates of 0.80, mid-83 sensitivity, or it's not very certain, because anything between 0.74 and 0.90. So it still means that, you know, we don't really know, because it's very different to have a 0.9 sensitivity than a 0.75 sensitivity. So there is a lot of uncertainties still. Regarding anterior segment OCT, a Cochrane team found 27 studies evaluating more than 15,000 patients. And because of the differences in the studies design using different parameters to measure and quantify the anterior chamber angle, they weren't able to meta-analyze the data and to pool, trying to gather and synthesize the evidence from all of this study was very difficult. And there was also difficulty in many patients identifying the scleral spur. So even though these pictures look very pretty, in real life, very often you use anterior segment OCT, you don't know where is a scleral spur, and then you don't know, if you don't know where is scleral spur, you don't know where, you know, where is the angle, and the interpretation is difficult, if not impossible. Anyway, so this Cochrane review reported that Van Herrick performed as well as the anterior segment OCT, but we need better high quality studies to answer these questions. So at the moment, after all of this, what I'm trying to say, that there is no evidence that to replace gonioscopy with either Van Herrick or anterior segment OCT. There might be you know, again, a chance, but at the moment that wouldn't be, we don't have the evidence to support a change in practice. Okay, let's talk about treatments. And of course, diagnosis is very important, because otherwise, you know, the treatments, you know, is where all this pathway will start with proper diagnosis. And this is one of my favorite slides that I tend to update whenever I speak about this condition. You can see here the burden of disease, which is globally similar for open angle and for angle closure. And of course, it's fair to say that open angle is much more prevalent, but angle closure is less common, but is more aggressive, tends to have much higher pressure, so leads to blindness much quicker than open angle glaucoma in general. But you see the number of trials that can be used to inform our decisions, the vast difference in the number of trials for open angle or for angle closure. So that's highlights again that this condition is needs more attention, more effort between all of us, and to try to find more evidence about the management of angle closure. And now we're going to talk specifically about treatments in eyes without cataract, and I'm not going to talk about acute attacks. I don't think there is much new evidence about managing of acute attacks. A couple of, before we go into this, I'll just mention what's something obvious. If you have angle closure glaucoma and cataract, the best treatment is just take the cataract out, and that makes sense. You have cataract visually significant, and you're gonna kill two birds with one stone. Now, there may be an exception in patients that have very severe angle closure glaucoma and cataract. Without any evidence, my personal practice and preference is to doing combined phacotrabeculectomies, again, in people with cataract and severe glaucoma disease. And regarding acute attacks, again, you know, thinking, well, there's nothing new. We can talk about that a bit later if you want. So I think that we'll start with the primary angle closure suspects management. Again, this is the narrow angles with everything normal. And these are recommendations from textbooks and guidelines to do laser iridotomy in these people. Now, this will change, if not has changed already, mainly because of the ZAP trial. I think that the ZAP trial is, well, we're going to review this very briefly. So the ZAP trial is a trial that compare laser iridotomy versus control in a large group of participants from China. So I don't have the couple of slides here, bear with me. So they recruited over 700 participants, and they followed them for 6 years. And the difference between the control eye in the same person and the eye that received the laser iridotomy was very small. Very few people develop high intraocular pressure, again, after 6 years. So the authors, they published this paper a few months ago in The Lancet. They have proposed that we don't need to do laser iridotomy in narrow angles, in primary angle closure suspects, only perhaps in high risk cases. And to me, the high risk cases are those that have very high hyperopia, and also those that have perhaps family history. Certainly the fellow eye of someone who had an acute attack of angle closure. And also perhaps high risk would be people who have narrow angles and have a retinal disease, for example, diabetes, and they require regular pupil dilation. But anyway, so that's something for debate. Now let's talk about, you know, people that have significant disease. These are people that have narrow angles and high pressure, or glaucoma, or glaucoma. So again, the guidelines, you will be, the standard management would be to do laser iridotomy and medical treatment and then if it doesn't work, you can escalate the treatment. We are gonna talk about Eagle in a second, and Eagle would be the initial intervention instead of laser PI. But let me tell you a little bit about laser iridoplasty. I don't know how often it is done locally by your team. I will just tell you what the evidence is telling us. So the laser iridoplasty, again, in chronic angle closure glaucoma, would be potentially relevant because we know that a lot of people, at least 1/3 of those who have angle closure after laser PI, the angle remains closed. So should be proactive and try to open the angle, perhaps with laser iridoplasty, and that's the critical question. So there are a few trials, and the trials evidence is telling us that there's very little efficacy regarding intraocular pressure. So either you compare with not laser peripheral plasty as control, or you compare with prostaglandins. The Argon laser peripheral iridoplasty is not very effective at all to reduce the pressure, even though it may open the angle a bit. So that's the evidence at the moment, and I personally don't use this intervention for chronic management people, the non-acute. In the acute setting, I think that it can be potentially useful in patients with an acute attack, but this is not what we are discussing at the moment. Okay, so we're going to one step back again. What's the best initial treatment for someone who is initially diagnosed with angle closure glaucoma or angle closure with high pressure? And that was the question that we were trying to answer in the Eagle trial. Sorry, and just I think I mixed up. These are the slides of the sub trial. I'm just going back for Pierre. So the Eagle trial, again, was a pragmatic trial trying to compare clear lens or phaco in people without cataract versus laser iridotomy. And here we randomize patients, not eye. So if someone has bilateral disease, they would receive phaco in both eyes if they were randomized to phaco, not at the same day. And if they have angle closure disease in both eyes and were randomized to laser iridotomy, they would have laser iridotomy on the same day in both eyes. And we follow the people for 3 years. And we encourage the local surgeons to escalate another medical treatment or surgical to meet the target pressure. So for example, someone who had a laser iridotomy and required more treatment, of course, they would have more medical treatment. And if they had required glaucoma surgery, and the surgeon wanted to consider phaco, it could be accepted a crossover for managing the patient. So these are the inclusion criteria for the Eagle trial. So they had to have either angle closure with high pressure or angle closure glaucoma with mild to moderate disease, at least 2 quadrants of angle closure, had to be newly diagnosed, up to 6 months. Age is a very important consideration. We enrolled only participants over 50 years for several reasons. Of course, they had to be phakic and without cataract. It was a multi-center trial that in the UK, we also recruited participants in Singapore, Malaysia, in China, and also in Australia. And we recruited over 400 participants. And this is the results, the main results. So the EQ5D, this is a quality of life measure, is a general quality of life questionnaire that evaluates the general health of a person. And this is the instrument of the questionnaire that is used in the UK to decide on policy, on what, you know, our hospitals that are tax funded will support or not support. And there is no visual question in the UK 5D. They are only general questions. But we were able to capture an improvement in the FACO group. And that improvement is very small, 0.052. That improvement, again, is modest.
Augusto, I think he's out, right?
I don't know. We lost him.
No, he's still there.
Yeah.
Yeah.
But by any means, we cannot see him anymore. Augusto.
He's back, yeah.
Okay, Augusto, the presentation was out of the screen. Can you hear us? Your microphone is mute.
Can you hear me?
Yes, now we can hear you. Yes, good.
So where did you lose me?
Just have a minute before.
Yeah.
It was like 30 seconds, less than a minute. So try to upload again the presentation share the presentation. You were just on the eagle part, at least explaining the part of the questionnaire and the quality of life.
Okay, okay. Can you hear me?
Yes, good. We can't see your screen yet, but we can hear you well.
So you cannot see my screen now?
No, we can see you.
Okay, let me just share it again.
Okay.
Can you see the screen now?
No, I received a message that say that you are sharing your screen, but no the slides.
Oh.
Maybe, yeah. Try to go out and go in again. Okay, now we are in. Yes, thank you. And
Okay.
yes, great. And
Okay, sorry about that.
no, please.
So I was telling you that this is the primary outcome, the generic quality of life instruments that is used by the UK Health Service. So this difference between the FACO and the laser PI group was small, modest, but still clinically significant. And also from the policy makers is also significant. Now, regarding the pressure difference between groups, the FACO group was a bit lower, about 1 millimeter of mercury lower than the laser PI. However, I think that we all agree a difference of only 1 millimeter of mercury is not clinically significant. It's very small to justify an operation. But what I will want to say that I still believe and we still support that the lens extraction is more effective because you're going to see now the difference in the medications, number of medications, and also in the number of surgeries across the 3 years. So again, just to emphasize, this is the pressure difference at 3 years. If the patients had surgery, we did not exclude them from this analysis. They were still part of the 3 years comparison. So at 3 years, you can see that in the lens extraction group, 60% of participants were well controlled on no medication, and only 21% of the laser group were without any medications. And you can see there's also a difference in the mean number of medications. So that tells me also that the again, even the IOP is not very different. The difference in the medications need is very substantial. And there's another evidence that the lens extraction is more effective, because in the laser group, 24 participants, that's over 10%.
Augusto, can you hear me? Because we lost we can see the slides, but we lost the audio from you. Mute and unmute. Yes, right now?
Okay, what about now?
Perfect, perfect. Sorry to interrupt you so much, but you know, as soon as I feel that we lost the...
Please.
Okay, great. Go ahead.
Please.
Go ahead.
Please. So just to recap, so I think the evidence is solid in favor of the efficacy of lens extraction for a superior than laser iridotomy regarding intraocular pressure. Not only because, you know, there is a bit of difference in the IOP level, but again, they're very significant that the number of medications and the need for glaucoma, the number of glaucoma surgeries was much greater in the laser group. So on balance, lens extraction is much more effective than laser. Now, in the lens extraction, we have 2 cases of PC rupture. And again, this is another interesting consideration. Statistically, it's not significant, but as a surgeon, this is very significant to know that this, it makes sense. Posterior capsule can break, and of course that's something that requires, you know, discussion with the patient about the small but potential significant risk. Now this is some data about the refractive error of people who received a phaco in the EAGLE trial. And you can see this is the graph representing the aim or attempted spherical equivalent and what was achieved, the difference. And this is the same data, but in a different format. So what you can see here is the error that, yes, the majority of people would be within half a diopter. That would be the 3 central columns would be those people that had a refractive error of less than half a diopter. But you can see that there is a significant number of people that have a large error in the refractive outcome. So that's something that in a way, it may not be surprising because we know biometry is less accurate in smaller eyes with hyperopic. But again, that's another consideration that we need to reflect upon. And the cost effectiveness, the perspective again is from the perspective of the health service provision. And yes, the catch-up operation is more costly as an initial intervention, but in the trial is cost effective because again the lens extraction is more effective, and also in the long term is cost saving. So it's just beyond cost effectiveness. We also save money using the lens extraction. And just to finish, a few implications about management of angle-closed glaucoma. So people with narrow angles, with no high pressure, certainly we wouldn't consider anything like lens extraction, not even laser PI if they have relatively low risk. I think still the laser PI would be advisable in high-risk patients. As I mentioned before, those with high hypermetropia, family history, retinal diseases, or fellow eyes, someone with an acute attack. But the policy and the guidelines are going to be changed. The European Glaucoma Society guidelines will be published later this year. And again, this is going to appear in the new guidelines, the different change in recommendation. And also regarding the lens extraction, the implication of the EAGLE trial is that we should offer as an option lens extraction to people over age of 50 without cataract that have, again, angle-closed glaucoma, significant disease, or high pressure. Of course, then at the end, the trial evidence is helpful for establishing this conversation. But again, how I use the evidence is to tell patients, listen, we have an option. Most people do well, and the quality of life is better, and the glaucoma control will be better with lens extraction. But some people and some surgeons are more risk averse, and that's absolutely fine. I think again, this is useful to be able to offer this option, but the trials doesn't tell us that we all must do lens extraction in everybody. That wouldn't be common sense. I mean, common sense is informed by evidence, and that's merging both is what the way to move forward. And then another word of caution is that the EAGLE trial may not be generalizable to people that were not part of the trial. I'm thinking specifically younger people, let's say with plateau iris. We don't know whether the lens extraction, because the younger people have, are able to accommodate. They tend to be perhaps more demanding and perhaps less tolerant to some suboptimal outcomes. Well, again, from the point of view as a surgeon, taking the lens out in someone without cataract tends to be very easy and very quick. However, that's not always the case, and these are patients that sometimes, occasionally, can be challenging, and removing the lens, without cataract, and something that you can encounter. Anterior chamber may be shallow or very shallow. You can have posterior pressure, iris prolapse. You're working. It can be expected. I always do in all my phaco quite anterior paracentesis, starting 1 millimeter anterior to the limbus. I don't like limbal incisions, perhaps exception of very highly myopic patients. But regular phaco and certain angle closer, I do start 1 millimeter anterior to the limbus for my paracentesis. And of course, chances of pure pupil dilation. Biometry in the small eyes. Again, in EAGLE trial, we had significant errors, and some surgeons use SRK2 or SRK-T, and that's not a good formula. Haigis or Hofer-Q is better for hyperoptic eyes. And of course, just to conclude, this is a cost-effective intervention, and actually it's cost savings in the long term. And this is my last comment. So it's still a condition that is a serious disease in some people, or in general, it's a more serious disease than open glaucoma. And there are many things that we don't know. And I would encourage, all of us to keep, making our efforts to understand better this condition. So thank you very much. I'm sorry for the technical glitch, but I'm very happy to answer some questions. Thank you.
Thank you, Augusto. Great talk. And technical conditions are always a problem everywhere, especially when we are on webinars. So the important thing is that we were able to go back to the critical points that we want to clear. Excellent. There is one questions on the done by Dr. Jose de Paulo. I'm going to go straight to that one because I think it's regarding to the Eagle study. And the question said, how many patients on the LPI group opened the angle? And if was gonioscopy after the LPI done or then ALPI? That's the question.
Well, that's a great question, Jose. Thank you very much. So yes, part of the protocol was to look at the gonioscopy and the angle, and it's reported in the main paper. And overall, yes, the laser PI did open the angle, but what we had here, and again, that's a challenge we have investigators. We have a lot of investigators not reporting the gonioscopy findings. So we lost a lot of data from gonioscopy. So it was a secondary outcome. And so that's a weakness of the trial that wasn't reported consistently. The other aspect about, and again, that is another challenge that we have as investigators in this condition. We were asking all the investigators to report the angle as degrees of opening between 1 and 360 degrees, and they were reporting okay, sorry, another disconnection. Can you hear me?
You were comment that they were reporting on the gonioscopy?
Yes, so they were reporting gonioscopy, and they were reporting gonioscopy. We were asking them to report gonioscopy in degrees, but many of them didn't report the post-op gonioscopy, so we didn't have any data. And many of those who reported per quadrants. So it was just, the data was very poor quality.
I see. So, yeah. Well, I guess, you know, sometimes on these trials, give us, as you mentioned, and I have to say, Dr. Azuara Blanco is one of the collaborators in the European glaucoma guidelines. So I guess that from out of all of these study or trials, give us a guidelines. But as you mentioned in one of your comments, you have to apply these conditions and these specific patients included in the study into a different population. After being almost 3 years here in Saudi Arabia, we have a very particular kind of patients. And for example, here you find a lot of angle-closer glaucoma, chronic, a lot of them, and a lot of them associated with pseudoexfoliation. So I guess that the way you face these kind of cases, it cannot be the same way that you were describing in the Eagle study.
Yes, that's a very good point. I'm changing the room because I think that part of the problem, technical problems, I had less Wi-Fi. So yes, absolutely. Pseudoexfoliation is, we don't have much pseudoexfoliation in Northern Ireland or in the UK, and I know it's very prevalent. And I don't think we had any pseudoexfoliation in the Eagle trial. It is very different, of course. It's very challenging. So the profile of complications of taking the lens in an eye with exfoliation is very different. So yes, I don't think that the results of the Eagle can be necessarily extrapolated with someone with pseudoexfoliation and narrow angles, which again, is a more challenging condition.
Yeah. Some questions that we have here, and while we talk, you know, there is one from that says, when should we perform cataract surgery in acute angle closer attack?
That's another excellent question. Yes, thank you. So if the angle closer attack is resolved with laser PI, then I would wait a few months if possible. But the lens extraction could potentially be required or a good option if you have an acute angle closer attack and the pressure is not well controlled It has a, and that's something that sometimes happens. I would still want to wait at least 2 to 4 weeks for the eye to settle down, try to manage the inflammation, and try to optimize as much as possible. So I would be not, I would want to wait again a few weeks, and of course, and that would be a good option.
Okay.
Yeah, may I, Dr. Conrad?
Please, go ahead.
Yeah, thank you. So thank you so much for the excellent presentation, Dr. Blanco. That was so engaging because we see a lot of those cases here in our region. And I think you were asking about the prevalence of primary angle closure glaucoma in the Middle East or Saudi Arabia. Well, the latest data that we have was a publication by Professor Salih Al-Abaidan from the King Saud University. That was, I think, on 2011. It's a relatively old, but it brought us a lot of information, excellent information. They studied all the patients presented to their institute for 2 years, from 2006 to 2008. And they concluded that almost 46 point something to 47 were primary angle closure glaucoma, which means that almost half of those patients were primary angle closure glaucoma.
Wow.
So, yeah, so the prevalence is really high here.
Wow.
So I think we have a different pattern of types of glaucoma than the Western area.
Yes, it makes sense.
Thank you, Dr. Augusto. May I talk, Dr. Conrad?
Oh, please go ahead. Yes.
Yeah. Thank you for this nice presentation and to give us, as a clinician, an overview about those big clinical trials. I have a question. I don't know. Do you think the ethnicity will affect the management that you mentioned in EAGLE study? Because as I remember, around 30% of the patient was from Chinese. Is this going to affect the type of management regarding either clear lens extraction or doing like the synecholysis or BI alone?
So if I understand the question, you're asking whether there may be ethnic differences in outcomes between Chinese and European populations, and perhaps Middle East. Okay, so we looked at the subgroup analysis of Chinese versus European populations, and we didn't see any difference in EAGLE. But what I would say is that the EAGLE study was not designed, was not powered to detect difference. The question was not, if we want to ask that question with certainty, we need to, power it substantially, with more patients with Chinese, because again, only 30% were Chinese. So we didn't find any difference. So it's still a bit of a question unanswered. And as it's been discussed, a Middle Eastern eye may potentially have different outcomes. So it's always an issue of translation of research in different ethnic groups. Personally, I think, again, with all these caveats, because we didn't find a difference between 30% of Chinese and 70% Caucasians, I think it's likely the lens extraction will be equally effective and more effective than laser PI, I would suspect. But again, I don't know for sure. And gonioscopy, yes, I mean, we didn't, again, it was a pragmatic trial. I think there's only one surgeon, only one case that has gonioscopy in the EAGLE trial. And that's something that I think that personally, I don't use it in the chronic stage, but in the context of, let's say, we mentioned before, and it's relatively uncommon in my area to have someone with acute angle closure that is not responding very well. I may do a lens extraction to manage the pressure better, maybe a month after the acute attack. And then I would, try and see whether I can do a bit of gonioscopy with heavy viscoelastic and perhaps gonioscopy visualization. There are some trials on gonioscopy suggesting that it's effective to help reduce the pressure. So some colleagues will use it more than I do. The trials looking at this particular intervention are small, and they are not definitive. But yes, it's a lot of surgical variability around goniosyncytialysis. I think it might help in some cases.
So you didn't think that having like 30% of Chinese in the Eagle study was a sort of limitation to the study, Dr. Blanco?
Okay, in a way it could be a limitation, but it could be a strength, because again, in the Chinese population, we found a similar intraocular pressure reduction than in the Caucasians. So there was no difference. So I think that we can interpret both ways.
Mm-hmm.
Conrad, is it okay if I ask a couple of questions?
Please, please.
Hi, Augusto, nice to have you.
Thank you.
So I've got two questions I was thinking of. One is, we've probably all seen that one patient in the clinic who we did gonioscopy and thought the angle wasn't occludable, and then came back to the emergency a couple of weeks later with an acute attack, at least one during our career, right? Exceptionally rare. So, you might have somebody who says, well, I would rather do 100 PIs, right, in patients who never develop angle closure to save the sight of that one person. So what would you say to that person?
I think that's a fair comment, and again, especially thinking that the ZAP trial may not always be generalizable. So I don't think I can say that's a wrong approach.
Okay, good.
Absolutely not. What we are, we're trying to say from the guidelines perspective and UK or European-wide perspective, what we're trying to say that, not everybody will need a laser PI. And again, it's different, especially the narrow angles is a spectrum. And we are trying to do guidelines, and it's very difficult to say, this is in a guideline, this is a very narrow angle.
Yes.
Or sometimes some people only have 2 quadrants.
Exactly.
And,
because,
and you can see a bit the trabecular meshwork, and there's borderline. And before we say, okay, let's do PI, we follow the guidelines. And now I would be comfortable of not doing the PI. But again, how you practice again, and also your personal experience is all important. And again, because ideally we would want to know the risk of angle closure according to different phenotypes or ocular characteristics. Yes. And ideally we'd like to know, okay, you have a lot of people with these characteristics to the anterior chamber, an angle, an iris insertion level, and this amount of pupillary block and this amount of plateau iris, this is the risk of angle closure.
Yeah, right. My worry is always that people forget about clinical intuition, which
as well, absolutely. And again, and this is an art, and gonioscopy is one of the most difficult skills to teach to the residents. And it's, and sometimes I consider myself to be experienced. Sometimes, I think I need to do the cornel weights because I cannot interpret the angle very well. Sometimes it's very difficult. So I think that, the message that, a lot of people with narrow angles don't have any significant risk, I think it's an important message. But, the decision making has to be individualized. And if you feel that the patient will benefit, there's nothing to say that, otherwise.
Great. And the second question I have is that, in the Eagle trial, obviously when you have treatments that are fairly obvious to the clinician who's managing the patient, right, it's impossible to blind the treating clinician who sees the patients after the intervention, right? So in this particular type of trial, you can't blind the clinician as to whether the patient had a clear lens extraction, whether they had a PI. To what extent do you think that could be a bias in the study?
Well, that's a very good question. So we tried to mask as best as we could the intraocular pressure because that's a primary outcome. So we use a 2-investigator protocol. So there would be one person measuring the pressure without looking at the Myers, and there would be a second person reading reading the tonometer number. So that way, in a way, we're trying to address that risk of bias. I think that's very important, the risk of bias. We are all biased, and the protocol, we thought about that, and that was a pragmatic solution. So in a way, we try to minimize that risk of bias. I think it's very real and a very good point.
And what about with regard to restarting medication? Was there kind of strict criteria on what level of intraocular pressure?
Good point. And again, that could be potentially biased. No, we allowed, it was a pragmatic trial. We allowed the clinicians to introduce a treatment whenever they consider necessary. We had some guidelines. So for example, you had a moderate glaucoma, we were suggesting to reduce the pressure to the mid-teens, but the decision-making was not centralized.
Well, in a way that represents real life, right? So that's
exactly,
what we're doing.
And that's absolutely. And again, it's a weakness in a way, because you can say clinicians are biased, but it's a strength because it represents real life practice.
Thank you very much.
So for those patients who are planned for phaco, Dr. Blanco, what are your thoughts regarding combining this with the ECP, endocyclophotocoagulation?
Well, I don't have personal experience with ECP because we don't have the gadget in our unit.
I see. Okay.
But what I will tell you is that someone that has severe glaucoma and significant disease and high, and high pressures, I prefer to do phacotrabeculectomy.
Excuse me, Dr. Corrad. Just one more question. Thank you again for this great presentation, and thank you again for being with us, Dr. Blanco. So one more question regarding the decision to go for phaco or clear lens extraction in susceptible patients. Do you depend only on gonioscopy, or you have to go for anterior segment OCT and see the lens position and the vault and everything? What's the parameters do you depend on?
So I don't think we need gonioscopy to make, I don't think we need anterior segment OCT to make the decisions. Because, and so I base my decision only on gonioscopy. What I was telling before is that ideally we should all be doing anterior segment OCT to try to learn more whether the different features, the lens vault or the degree of angle closure that can be quantified is a predictor of the outcomes. So that would be the next level. I think that would be a very important question. But at the moment, we don't know whether, the different anatomy of the anterior chamber within the group, the different types of angle closures is going to help us predict the outcome. So at the moment, I just base my decisions only on gonioscopy.
Good.
I think we have time for one more question, because in 2 minutes we will have the full hour. And as you can see, Augusto, it passed very fast. Anyways, the last question that is here on the questions and answer plot said, do you have any course of follow-up a patient that is suspicious of primary angle closer, and even if it has a patent PIs, you have a protocol, or you follow those patients for a period of time, or you think that this is lifelong follow-up?
Well, I don't think we need to follow up those patients. I think we, personally we can discharge her. I mean, we have an optometrist system in the UK, that community optometrists, but I don't think they need to be seen in primary anymore.
Right.
There is another question that I can take, because I think if that's okay, Conrad, about someone with single eye with advanced angle closure glaucoma, and my combined or trabeculectomy. I think if it's angle closure and the angle is still closed after PI, I would do a combined phacotrabeculectomy. But again, if you don't do often phacotrabeculectomies, then perhaps don't do it in this patient with a single eye. But in my hands, I'm very comfortable doing phacotrabeculectomies. Now, if the angle has a history of angle closure glaucoma and the angle has opened after the laser PI, then perhaps we don't need to remove the phaco, if that makes sense. Just do the trabeculectomy.
Yeah, absolutely. I think that probably we have to adjust always our surgeries according to each clinical and individualized case. That's the best.
Absolutely.
Dr. Blanco, for those patients who are less than 50 years of age and they had an attack of angle closure, do you think we can apply the eagle here? I mean, what's your protocol for those patients?
No, I don't think we cannot use the eagle trial, although sometimes I do take the lens out. So I think that I don't have, again, a protocol, depends on the age, you know, it's one issue, you know, but of course, I would try to manage the glaucoma without taking the lens.
Okay.
But if you do the laser PI, the pressure is high and the angle remains closed, I think that, you know, that the taking the lens would not be my first intervention, but certainly if the laser PI medication will control it, I would consider it.
Yeah.
Augusto, last thing, and you are my friend, and we have confidence, and I know that this is not a good question that I'm going to ask you, but in these cases of patients that you are planning to remove the lens, will you consider by any means, and in which cases, multifocal intraocular lenses?
No. For several, I mean, but anyway, so again, that's my personal preference, but I don't think necessarily wrong. If they have significant glaucoma, my impression is that there is loss of contrast sensitivity and the multifocal lenses may also add to that. If you have someone with just high pressure and a healthy optic disc, then yes, it would be an option as in anybody else.
Good, good. Because I don't like the multifocal in glaucoma patients. That's why.
Yeah, for the same reason, yes.
The follow-up of these patients, and now there are studies that show that even the multifocal lenses will be affecting the OCT as well as the visual field. Great.
Yeah, if they have significant glaucoma, I don't think it's a good option. If they have only high pressure with healthy nerves, might be okay.
But here, most of us, we are glaucoma guys. So we think about glaucoma in a state of thinking about the cataract. So that's great. Any other comment from the group of panelists? Anything else that we want to say to Dr. Augusto Azuara Blanco?
We just want to say thank you so much for joining, Dr. Blanco.
A big pleasure. Thank you very much. Nice meeting you all, and gracias, Conrad.
De nada, Augusto. It's a pleasure to see you, really, really. Okay.
Pleasure. Keep well.
Have a good day.
Have a good day, guys. Thank you.
You too. Stay safe, please.
Stay safe. Yeah.
Bye.
Bye-bye.
Thank you, Professor Blanco. Stay safe.
Thank you.